I'm David Falconer. I'm one of the trustees of Just Support UK. But prior to my involvement with Just Support UK, I was the commercial lead for Just for Pfizer. And it's actually coming up to the 10th anniversary when sunitinib was launched. So it's now been around a very long time. After I retired from Pfizer, I decided I wanted to share some of my knowledge and expertise in the subject of GIST, and I joined as a special advisor, and I'm now a trustee. Not quite sure. That's it. So I want to really touch on the management of tyrosine kinase inhibitors, the associated side effects, and specifically around the drugs, because in my view, and I used to have to engage with virtually every GIST clinician in the UK for many years, one of the things that was never explored with patients, because they're often administered for a very, very long time, it's very crucial to manage the drug-related side effects. And the adverse effects, they reduce patient compliance, as well as lead to decreased drug exposure with drug holidays or dose reductions. And in the very early days, for example, of sunitinib, when clinicians had very, very limited expertise, you were getting situations where they were saying, you can't tolerate the drug, I think you should stop taking it. And that happened many, many, many times. And we're also going back to the times of primary care trusts who were funding drugs like sunitinib. And people, for example, in the north of Birmingham had access to sunitinib, people in the south didn't. People were selling their homes and moving to other parts of the country simply to get funding to access drugs. But for just patients receiving any TKI, it is generally accepted that it's important to maintain continuous drug administration at a sufficient dose. And I will mention the French trial that shows you're actually far better to stay on treatment than to stop treatment, even for a limited period of time. So we're talking about empowerment, and what I want to try and do very briefly is to empower. One of the duties of a trustee is to empower patients to have dialogues with their clinicians. And I would like to agree with you, but then we would both be wrong. That's a mantra. And that is because far too often, when it comes to talking about drug treatment, nobody has a definitive answer, not even the clinicians, because there is no medical evidence, no clinical trials, no research being done to back it up. But it's important to have an engagement. Now, if we look at the 3 drugs that are licensed for GIST at the moment, for Gleevec, you've got the recommended dose of 400 mg a day. For Sutent, it's 50 mg with 4 weeks off and 2 weeks on. 4 weeks on and 2 weeks off. And for Stervega, regorafenib, it's 150 mg for 21 days and then 7 days off. Now, if you work for a pharmaceutical company and you're engaged with a clinician, you cannot, under any circumstances, talk to that clinician about anything else other than those licensed doses. These are all from the summary of the product characteristics. It is not permitted to talk about any other variation other than the licensed indication. But if you look at the SMPC, or the SPC, you will find on the imatinib SPC, there is mention of dose adjustments for GIST.
So what's SPC?
SPC is a summary of product characteristics, which basically is the licensed information and indication for the actual drug. And this applies to all of the drugs, so they are accommodating the use, and it is generally accepted as far better to stay on treatment than to go for a dose and to have a dose reduction rather than to stop treatment, or even in some cases to have a drug holiday, which some clinicians will advocate. And when you look at sunitinib, on their summary of product characteristics, which is the information they give to clinicians, it says there is the opportunity for dose interruption or dose modification. And these may be made in 12.5 big increments or decrements based on the individual safety and tolerability. They go for 12.5 mg because the drugs are 50 mg a day is what's recommended, so you can get 4 12.5 mgs, and that makes up your dosage. And when you look at sunitinib, the licensed treatment schedule is 50 mg, 4 weeks on and 2 weeks off. But there are so many unlicensed schedules out there. For example, 2 weeks off, on and 1 week off. 37.5 mg continuous daily dosing, so you're not having any time off, but you're having the drug on a reduced dosage. 37.5 mg 2 weeks on and 1 week off. 37.5 mg for 3 days and 25 mg for 2 days on a continuous dosing regimen. And there are many, many, many more. 25 mg continuous daily dosing. Professor Wall up in Sheffield has a patient who's been on 12.5 mg, which sometimes is referred to as a maintenance dose, for 5.5 years. So it is important, if necessary, if you're finding it difficult to manage your drug treatment, to engage with your clinician, talk to him, and decide what is best rather than dose interrupting. Regorafenib, as you can see, it's 160 mg, that's what they recommend orally, for 21 days and then a 1 week cycle. But even with regorafenib, it says it may be that in patients who are frailer than those included in the clinical trials, a starting dose lower than 160 mg, in other words 120 or even 80 mg, might be appropriate. And this dose can then be escalated within the first 1 or 2 cycles to reach the target dose of 160 mg. And this is from Optimizing Treatment Outcomes with Regorafenib, and it was published just last month in The Oncologist. So all of the drugs have a licensed indication, but they all have scope to stay on treatment, but at a variable dose. And what I'm suggesting and recommending to you is that you engage with your nurse and your doctor. If you find it very difficult to manage the side effects, talk to them. The TKI, one of the problems with all of the TKIs, imatinib, sunitinib, and regorafenib, is no 2 patients respond the same. Every patient is different in terms of response. I've met patients who have never had fatigue, who've never had hand and foot syndrome, but I've also met people who have been virtually bedridden because of hand-foot syndrome for a very, very long time. Some patients will have very, very few side effects, particularly those on imatinib. Patients in general are able to tolerate imatinib fairly well. If they have got side effects, they're usually of a low grade, grade 1 or 2, which means they're fairly easy to manage, and either your clinician or your nurse will be able to advise you how to manage them. Clinicians have got a lot of experience in treating other disease areas in cancer where they have similar side effects. So, they've got a lot of expertise that they can give you. So engaging with your nurse and your oncologist is important when you're talking about TKI side effects, but don't feel that you have to maintain the original starting dose. There are several aspects to managing side effects. There's the dosage and titration. Titration just means going up and down the scale. When to take the medication. Drugs to alleviate the side effects that you may be having on any treatment. And there are lots of other practical aids. And if you look at dosing and titration, at what time of the day do you take your medication? Now this sometimes works for some people. They don't take it until just before they go to bed at night. So when the drug is working at its most effective, hopefully you're sound asleep. Not taking it with breakfast first thing in the morning, so when it's being most effective, you're having to endure and go right through the day. And I'm encouraged to see that Ivo here is nodding in agreement on a number of these points. So what time of the day you take your medication is really important. Think about doing something different rather than stopping taking treatment. Do you take the full dose at that time? And what I mean by that is, if you were on 400 mg of imatinib, would you take 200 mg in the morning and 200 mg at night? You're still getting 400 mg a day. Again, it's something that you can enter into conversation. And patients will find, if you split the dose, certainly with sunitinib, and I believe with regorafenib, a lot of patients have actually benefited from the quite intolerable side effects that they can get simply by splitting the dose. So they're staying on treatment, they're staying on the dose that the clinician wants them to take, but they're splitting it over the day. And these small changes, literally changing times and dates, can make a big difference in terms of how you're able to tolerate the side effects. So when to take the medication, I mentioned last thing at night, so that the drug is working when you're sleeping. Does it affect the effectiveness of the drug? The answer is probably not, because you're still taking the same amount of dosage in the same amount of time. Importantly, though, you have to have the right mix of tablets in order for any change in medication. Going back to when sunitinib was launched 10 years ago, there was a major problem. Virtually every clinician wrote a script for 50 mg, which meant if a patient was on treatment for 2 weeks and then he found it very, very difficult, tens, hundreds of thousands of pounds were wasted because the patient had to stop treatment, had to go away and get a completely new mixture of tablets made up of either 25 mg or 12.5 mg in order that they could titrate downwards and take a lower dose. So again, it's all about having a discussion, using your empowerment and talking to your oncologist or your nurse. Because they're taking for very long periods of time, maintaining dose intensity is generally felt to be important. But as I've highlighted, adverse events, they can reduce patient compliance and the clinical effectiveness of the TKIs. So staying on the maximum tolerable dose is what is most desirable. One side effect I really have to put up is the hand-foot syndrome. I'm not going to go into all but www.notjustforcows.com, I happen to be involved in that being associated with for patients with hand-foot syndrome, and it came from a patient in Swansea who was a renal cancer patient, and he was also a farmer. And it was very, very early days with sunitinib, and he was given his medication went off, and after a few days he found it very difficult with the hand-foot syndrome. But he knew that he gave his cows, he used to take them on the udders of the cows, especially in the winter, to keep them flexible and soft. So he tried it on himself, and it worked wonders, and he went back and he told his oncologist in Swansea, and since then, www.notjustforcows.com has done very, very good business out of the cancer patients. It's called Utterly Smooth. And interestingly, Bayer very kindly have sent us a number of patient starter packs, and one of the contents is Utterly Smooth. And if there are any regorafenib patients here today who would like a pack to take home with them, I have some at the back of the room. I don't get any commission from Utterly Smooth, by the way. But simple things like getting thicker socks, etc. Your nurse knows all about them. Talk to her, find out what it is they recommend. Really important, I did mention that the pharmaceutical companies are only allowed to engage with clinicians in licensed indication and talk to them about doses for licensed indication. But unlicensed schedules, they're not improper. So, for example, going to sunitinib, they recommend mg. Now, if you're a patient, either GIST or renal, and you presented at University Hospital Cardiff, no patient there is ever started on 50 mg. They're all started on 37.5 mg continuous daily dosing. And when you do the maths over a 6-week cycle, you see that although you're on a lower dose, you're actually getting more of the drug in the 6-week period than you would if you stick to the recommended or the licensed indication. So finally, Eva touched on mutations. It's really, really important because it can help towards getting personalized therapy. We talked about exon 11. You're better off on imatinib if you've got an exon 11 mutation, but also on some of the other exon mutations, you're better off in some of the other drugs. Unfortunately, Philippe is not going to be with us this afternoon, but one of the things that we're aiming, that unfortunately does not happen as a matter of routine in England, is mutation analysis in all hospitals. The reason being that NICE does not regard it as part of the recommended, as a diagnostic tool for treating, for prognosis and diagnostics. And this means that it's not actually funded. Now the figure per patient to have it is about 150 quid. And as far as I'm concerned, to get mutation analysis done, and that's what Philippe Tanier does down in Birmingham for a lot of hospitals. It's not a lot of money, but you can get far better prognosis and diagnosis and never prognosis if you know what the exon mutation is than without it. If you're not members of the GSUK listserv, get onto our site. One of the best sources of information are the other patients who are on that listserv and to share their experience, their knowledge, and their coping mechanisms. The patient experience and knowledge is shared widely, and there's almost certainly someone else who are on their website who's been down the same patient pathway as you have, same journey. Your nurse is a valuable source of side effect management, as too is your oncologist. And I put the oncologist in brackets because far too often the majority of the sort of things that you would want to engage with is normally with the nurse. We've got several pamphlets outside. Please help yourselves, and please pass some of them on to your hospital, to your nurse or to your oncologist. Thank you. Yep. Yes, Judith.
I'd like to ask of David and Eva whether, if patients are on an alternative regime and doing okay, getting stability with better side control management, is this data being collected? Because this is incredibly valuable information, and surely we don't want to lose it.
Well,
I mean, it's anecdotal now. I mean, like David saying that Penella had a patient on 12.5 milligram per day of sunitinib for 5 years. That's incredibly useful information, and it ought to be widely available and put into the whole gamut of data for GIST patients.
Well, my response would be, it's certainly not in the pharmaceutical companies' industry's area of expertise, because they're only working to the license. They don't really want to know, as long as the patient can treat with their drugs. The situation is we're now collecting GIST data on a national basis from the time of surgery right through to death. It's only just started. That information from is only about 6 months old now. But we will have that data. We will be able to go in about a year or two's time, look at the data, and analyse what surgery they had, what treatment they've had, what dosage they were on, how long have they lived. It's incredibly important, as you say, and it's a shame because with all these variations going on the theme, one of our medical advisory board guys, Ramesh Balusa, he now puts a lot of patients on for example, on sunitinib, 5 days on, 2 days off. And if you do the mathematics, you're going to, on a 6-week cycle, you're going to get exactly the same dose, but you're not having to wait 4 weeks before you get your 2-week respite. You're only having to wait 5 days, and then you get your 2-day respite. But yes, it's something that I think could be done a lot more thoroughly, is finding out how patients do on unlicensed dosing.
It is a very interesting question, and a lot of it, as David says, will now be collected routinely as long as imatinib is prescribed electronically. There are still a lot of centres that prescribe imatinib on handwritten prescription, and that data isn't necessarily being collected. But perhaps to reassure you a little bit, you cannot go to a GIST conference where Ramesh Balusu is without hearing a talk about what to do with the doses and the side effects. So a lot of this information is out, and if your oncologist is interested and goes to conferences, then they will have at least an idea of what Ramesh does in Cambridge, and will use similar strategies.
And if your oncologist isn't interested, well, you change your oncologist, don't you?
Absolutely.
Any other questions? No.
I'm living with GIST for 16 odd years.
Yep.
2 open surgery, over 6 years in Gleevec, and now I'm living on a Sutent for 6 years. Now I'd like to ask, have you got a patient that living on a Sutent for how long?
Which dose are you on Sutent?
I'm on a 25. I started on 50.
Yep.
I came down to 37.5. The
No.
body couldn't take
So how long,
it. So I'm
have
on
you,
25.
how long have you been on 25 mg?
6 years.
6 years.
Well, more or less 6 years.
Another example of a maintenance dose. It's an unlicensed indication, but it's another reason. And one of the important things is that we, as trustees of GSUK, advocate patients, if possible, getting themselves referred to a tertiary referral centre. Because the more patients clinicians see of a particular tumour, the more expertise they themselves start to get. And if you go to a hospital that might only have 2 or 3 GIST patients a month, and another hospital is having 10 or 12 a month, you can be rest assured that the hospital seeing 10 or 12 patients a month are going to have an awful lot more in-house expertise in managing GIST patients than the hospitals that are only treating 1 or 2.
In answer to your question, in Nottingham, no, I don't. So I think you're doing exceptionally well. I trained in Leeds, and I know of a patient in Leeds who I saw as a registrar, who I think is still on sunitinib now. So there are patients, but you've seen from the curves that I've shown you that sunitinib, the treatment duration quite often is measured in a matter of weeks or a few months rather than years. So you do have patients that do exceptionally well. It's very difficult to predict who will and who won't. So you just have to sometimes go with the flow. And if it works, stay on it.
In my hospital before, that I was the only one living with a sleeping so and I did suggested that try 12 an hour type of thing, so I stayed on 25. There is another option that my oncologist told me that if students fail, there will be another one.
Very quick question, and I've raised this question at GIST conferences over the last 12 years. Gleevec, the standard dose, 400 milligrams a day, because I believe in the original trials that was about the maximum dose you could give without the toxicology being serious. Now, patients vary enormously in weight. Has anybody thought seriously that if you've got a patient who, for example, weighs 7 stone, thinking English money, you would naturally start them off on a lower dose than, say, if you've got a fairly well-built man of, shall we say, 15 stone? Is patient weight a relevant parameter for your dosing?
I'm not so sure about weight, but certainly metabolism is very, very important. And indeed, Ramesh Bulusu quite often does so-called trough levels. So he sees in the blood how low does the drug level go. In other malignancies, we use trough levels to look at compliance. So in leukemic patients, they have to stay on some chemotherapy drugs for a long time. They have toxicities. They might be young patients. A lot of young patients aren't quite so compliant. And then if things happen, you need to know why do things happen. So if the malignancy progresses again, you want to know, is that because the drug has stopped working, or is that because the patient didn't take the drug? So there is an analogy there. And indeed, Ramesh has got some data to show that if you look at the levels in the blood, you get some valuable information. Again, there aren't many laboratories that will do the levels for you, and in some ways, you need to be pragmatic. You know the 400 work, and you know that if the toxicities demand, then you can change the dose and you adjust it to the patient. But my personal approach is that you start on the recommended dose and then you see what happens and you take it, you play it by ear a little bit.